You know, usually when we talk about a medical diagnosis, there's this expectation of precision.
Right, like a clear-cut answer.
Exactly. You break your arm, the X-ray shows that jagged white line, and the doctor just points and says, "There it is. That's the problem."
Yeah, you cast it, you rest it, and it heals.
Right. The physical infrastructure of medicine is, it's designed to be highly visible.
It's visible, and therefore it's quantifiable. I mean, we like our problems to be neat and easy to categorize.
We really do. But then, you step into the world of adolescent neurodevelopment and behavioral health, and suddenly,
An X-ray machine is useless.
utterly useless. We're looking at a diagnostic landscape that is, well, it's entirely invisible to the naked eye. And that murky landscape is exactly what we're wading into for you today. Welcome to the Deep Dive.
Glad to be here, as always.
So today we're looking at this massive, fundamental shift in K-12 education based on a huge stack of research you wanted us to look into.
Yeah, there's a lot to cover.
For sure. We've got recent state policy updates, clinical psychology notes on adolescent behavior, and the operational blueprint of this Georgia-based teletherapy initiative called MentalSpace School.
Which is a fascinating model, by the way.
Oh, totally.
Yeah.
Our mission today is to figure out how public schools are moving beyond, just sticking wellness posters in the hallway.
Right, because posters don't really do much.
No, they don't. We want to see how they're trying to build actual functional infrastructure. And maybe more importantly, we're going to tear down the mythology of the mental health day to see what actually happens when a student takes one.
Yeah, that's the real core of the issue.
Okay, let's unpack this because the sheer scale of the policy shift happening right now is, frankly, it's wild.
It really is. We are looking at a fundamental redefinition of school attendance.
Wow, really? A redefinition?
Yeah, absolutely. Across a dozen states right now, with pioneers like Oregon and Utah kind of leading the charge. And, coastal states are rapidly following. The Mental Health Day has been legally codified as an excused absence.
So it's on the books.
Legally on the books, it carries the exact same administrative weight as having the flu or a stomach bug.
And it's not just a couple of places, right?
Yeah.
I mean, looking at the sources, it's Illinois, Maine, Virginia, Colorado.
Connecticut, California, Arizona, Nevada, and Kentucky.
That is a massive chunk of the country. And what really stood out to me in these policy updates is the engine behind that legislative movement.
Yeah, the origin story's incredible.
Right. Like you would think a shift this massive was, cooked up in a think tank or pushed by some massive coalition of pediatricians.
What's fascinating here is that the primary architects of this policy shift were the students themselves.
The kids. That's just wild.
Right. We're looking at a generation that has fundamentally destigmatized mental health within their own peer groups. They looked at the institutional framework, a framework that, excused them for a migraine but penalized them for a panic attack.
Right, which makes no sense when you say it out loud.
Exactly.
Right.
And they recognized the hypocrisy. So they organized, they literally testified before state legislatures.
Oh, wow. High schoolers testifying.
Yeah, and they forced institutional change from the bottom up.
The agency there is just incredible. But I have to push back a bit on the actual mechanics of this victory, looking at it from the perspective of an old school educator.
Okay, let's hear it.
So, if a kid has a physical fever, the mechanism of healing is really clear.
Right, they stay home.
Yeah, they stay home, their immune system fights off the infection, they sleep, and the fever breaks.
The body does its job.
Exactly. But what is the actual mechanism of a mental fever day?
That is the million-dollar question.
Right. Does simply granting a student a random Tuesday off actually fix a panic disorder? Or are they just like sitting on the couch scrolling through the exact same algorithmic social media feeds that might be fueling their anxiety in the first place?
That tension right there, that is the core of the debate happening in counseling offices right now.
I bet. It has to be chaotic.
It is. Are these days a necessary lifeline, or are they just sanctioned avoidance?
Sanctioned avoidance. Wow.
Yeah, and the research data gives us a very clear, heavily caveated answer. A mental health day is not an intervention.
Wait, say that again. It's not an intervention?
Not at all. It is merely a window of time.
Oh, interesting.
Yeah. The same 24 hours can either act as a crucial reset for a student's nervous system, or it can quietly reinforce a deeply problematic clinical pattern.
And what pattern is that?
It's known as school refusal.
School refusal. I want to dig into that term. Because, that sounds very different than a teenager just wanting to play video games all day.
Oh, it is entirely different. School refusal is a severe manifestation of anxiety or distress, where the student's autonomic nervous system essentially treats the school building as a physical threat.
Like a literal danger zone.
Yes, their amygdala is firing. Going to math class feels like walking into a lion's den.
Man, that sounds exhausting.
It is. So when a student in that state stays home, their cortisol levels drop. They feel immediate relief.
Because they avoided the lion's den.
Exactly. The danger is that the brain registers that relief and wires a new connection. Basically, school equals danger, home equals safety.
Here's where it gets really interesting. Because the danger of that quiet reinforcement is just so sneaky.
It really is.
It's like taking a painkiller for a broken arm. You take the pill, the acute pain subsides, and you think the problem is solved because you get to stay in bed and you don't hurt.
Right, you feel fine in the moment.
But the underlying fracture is still there.
It's still there.
Yeah.
And tomorrow, when the painkiller wears off, not only is the arm still broken, but the bone has started to set in the wrong position.
Oh, that's a great way to put it.
Yeah. The underlying anxiety, the bullying, the academic pressure, none of that was resolved by sitting on the couch.
Right. Nothing actually changed.
Exactly. So sending them back into the building the next day triggers an even stronger panic response because they've now tasted that profound relief of avoiding it.
Okay, so if the mental health day is just the painkiller, what is the clinical equivalent of setting the bone?
It's a great question.
Like, how do you stop that avoidance loop from solidifying?
It comes down entirely to what happens during that window of time.
During the day off?
Yes. The difference between a healthy reset and a slide into chronic school refusal relies on a very specific type of conversation.
Okay, like a therapy session.
Sort of. It cannot just be a parent asking, "Hey, are you feeling better?" over breakfast.
Right. Did you sleep well? Then cut it.
No, it has to be a structured dialogue that uncovers the specific barrier to reentry.
What exactly is triggering the distress?
Exactly. Is it a peer conflict?
Right.
Is it an undiagnosed learning disability, making reading out loud terrifying?
Right. You have to find the root cause.
And once that trigger is identified, the conversation must pivot to creating a tangible, realistic coping strategy for returning to the building the next day.
Wow. I'm putting myself in the shoes of a school superintendent right now, listening to this required criteria.
It's a lot, right?
It's terrifying. The state legislature has just mandated that I allow kids to take these mental health days.
Yeah.
But the clinical psychology says that if these days aren't handled perfectly, with specialized follow-up conversations to prevent avoidance loops,
then you have a massive problem.
right, I might actually be facilitating a mass epidemic of school refusal. That sounds like a catastrophic structural failure waiting to happen.
It creates immense systemic friction. I mean, the policy updates highlight that district leaders are now caught in a three-front administrative nightmare.
3 fronts. Okay, lay them out for us.
The first front is simply data and attendance accounting. When a state alters its legal absence categories, schools have to completely overhaul their tracking systems to understand the trends.
Oh, like looking for patterns.
Right. Are mental health absences spiking predictably during standardized testing weeks? Are they concentrated in specific demographics?
Because if you have like 40 kids taking a mental health day on the same Tuesday, that's not an individual psychological issue.
No, not at all.
That's a systemic school culture issue. But the data only tells you what happened yesterday. It doesn't fix today.
Exactly. And that brings us to the second front, which is the counselor workflow.
Which seems like the real bottleneck here.
It is the main bottleneck. Just consider the reality of a public school counselor. They are managing caseloads of 300, 400, sometimes 500 students.
That's absurd.
It is. They are dealing with schedule changes, college applications, lunch duty, breaking up fights.
Yes, just keeping the building running.
Right. Now, add the responsibility of triaging mental health requests. If a straight-A student asks for a day off after midterms, that might just be a healthy reset.
Sure, they just need to sleep.
But if a student is requesting their third mental health day in a month, that counselor needs to immediately flag that student.
Right. But then what? What is the protocol when a student crosses the line from needing a break to needing clinical intervention?
That's the void.
Because you can't just expect a high school guidance counselor to suddenly start running intensive cognitive behavioral therapy sessions between third and fourth period.
They don't have the time, and often they don't have that specific clinical training either.
Right. Which brings us to the third front. The parents.
Oh, yes. The family communication.
Because parents are reading the headlines. They know these state laws exist.
They watch the news.
Yeah, they call the attendance office and say, I'm excusing my child for a mental health day. But the front office staff aren't clinicians.
Not at all.
If there isn't a clear district-wide protocol, every single phone call turns into this subjective debate about what constitutes a valid mental health need.
If we connect this to the bigger picture, this is a textbook example of policy outpacing practice.
Policy outpacing practice. That makes a lot of sense.
Yeah. Mandating mental health days is it's a progressive, well-intentioned evolution in how we view adolescent development.
For sure.
But policy without clinical infrastructure underperforms. You are essentially handing schools a mandate to manage pediatric mental health care without giving them the personnel, the tools, or the funding to actually provide that care.
Which begs the question, how on earth do schools close that gap?
It's not easy.
No. I mean, you can't just snap your fingers and spawn 50 licensed child psychologists in a school district.
No, you definitely can't.
So that brings us to the case study in our sources, MentalSpace School.
Yes.
This is a targeted K-12 mental health support initiative operating in Georgia. And looking at their operational blueprint, it seems to be specifically designed to bolt onto a school district and serve as that missing clinical chassis.
It's a fascinating model because it doesn't ask the school to become a hospital. It integrates the healthcare system into the school's existing ecosystem. The core of their infrastructure is providing same-day teletherapy with a dedicated team of therapists assigned to each partner school.
Okay, let's talk about the mechanics of same day, because that is the part that honestly blew my mind.
It's unheard of in the private sector.
Exactly. If you are a parent trying to book an adolescent therapist in the private sector right now, you are making phone calls for weeks, only to be put on a 2-month wait list.
Sometimes longer.
Yeah. How does a teletherapy platform bypass that entirely for a public school?
By embedding the referral pathway directly into the school counselor's workflow.
Okay, how does that work?
Well, remember that bottleneck we discussed? The
Yeah.
counselor with 400 students who notices a kid taking their third mental health day?
Yeah, the one drowning in college applications.
Right. Instead of sending that family an email with a list of community clinics and just, hoping for the best, the counselor utilizes the integrated system.
You just click a button?
Pretty much. They flag the student, and because there is a dedicated team for that specific school, the student can access a therapist that very same day.
Wow. But logistically, how does that actually work during a chaotic school day? A kid is in biology class, they have a panic attack, they go to the counselor. Does the kid just open a laptop in the crowded main office?
No, they have protocols for that. Schools typically designate secure, private spaces.
Okay.
Often a small conference room or a dedicated wellness room equipped with a tablet or a computer. The student goes in, puts on headphones, and connects with their designated therapist.
That is so smart.
It removes the transportation barrier, the scheduling barrier, and the waitlist barrier all at once.
And it sounds like they handle a wide range of issues too, right?
Absolutely. Everything from acute crisis intervention and suicide prevention to ongoing family counseling. And they even have staff wellness programs.
Oh, for the teachers.
Yes. So the school counselor is finally freed up to do their actual job, knowing the clinical needs are being handled by licensed professionals.
But, anytime you mix healthcare and public education, you run into a massive wall of privacy laws.
Oh, the red tape is real.
Yeah, because the school is governed by educational privacy laws, and the therapists are governed by medical privacy laws. It usually creates this administrative Cold War where neither side can talk to each other.
That is precisely why the infrastructure of a platform like MentalSpace is so critical. Our sources note they are built to be strictly compliant with both HIPAA, which protects the student's medical information,
Right.
and FERPA, which protects their educational records. They create a secure legal bridge.
So they can actually communicate.
Exactly. The therapist can provide the school counselor with actionable safety plans or re-entry strategies without violating the student's medical confidentiality.
That is huge.
Furthermore, this specific model is designed to support the upcoming HB 268 mandate in Georgia.
Right. The legislative clock is ticking on that.
Yes, it is.
HB 268 requires schools to have these specific safety and mental health protocols in place by July 2026.
So it's no longer just a nice to have, it is becoming a state requirement.
Exactly. So what does this all mean for the bottom line?
The money.
Right. We have same-day access, dedicated clinical teams, legal compliance, and diverse, culturally competent therapists.
It sounds expensive.
Usually when you stack up an infrastructure list like that, the cost is astronomical. And public school budgets are notoriously strapped.
But the financial architecture of this model is arguably its most important feature.
Really? How so?
They aren't asking the school district to fit the bill for hundreds of hours of private therapy out of their general fund. They're utilizing the existing healthcare apparatus.
Right, the sources show that Medicaid covers these services entirely. $0 out of pocket for the family or the school.
Which instantly removes the financial barrier for the most vulnerable student populations.
That's incredible. And for families with private insurance, the network integration is massive.
Oh, they take almost everyone.
Yep. Looking at the list, they take Blue Cross, Blue Shield, Cigna, Aetna, United Healthcare, Humana, Peach State, CareSource, and AmeriGroup.
They've essentially cast a financial net that catches almost the entire student body without bankrupting the school district.
It's brilliant, and it seems like it's actually working.
Oh, the numbers speak for themselves. When you remove both the logistical wait time barrier and the financial barrier, you start to see the data actually shift.
Tell me about the data.
The internal metrics provided in the source material for this Georgia initiative show an 89% improved attendance rate among the students utilizing the platform.
89%.
Yeah.
That number is the literal antidote to the school refusal problem we were talking about earlier.
It really is.
If attendance is improving by nearly 90%, it means the mental health days are actually functioning as a reset, not an avoidance loop.
Exactly. The coping strategies are actually being built. They also report a 92% reduction in measurable anxiety.
92%.
And an 85% family satisfaction rate.
So the parents are happy too.
It acts as a proof of concept. When you pair the progressive policy of a mental health day with the actual clinical infrastructure required to support it, like MentalSpace School, the system works.
The days off stop being a void.
Right. And they start being a functional part of a student's healthcare. And for those interested in the details of their blueprint, the sources note, you can look them up at mentalspaceschool.com or reach out to MentalSpace School at shagetherapy.com.
Perfect. Yeah. Well, let's take a breath and recap the journey we've been on today.
We covered a lot of ground.
We did. We started by looking at a seismic shift in K-12 education, driven largely by students themselves, to legally recognize mental health days as valid absences across a huge portion of the country.
We then explored the biological and psychological reality of those days off.
Right.
We unpacked how an unmanaged absence can actually reinforce the dangerous cycle of school refusal by allowing the brain to associate avoidance with safety.
We looked at the immense pressure this puts on school administrators and counselors who are, suddenly expected to manage clinical outcomes without clinical tools.
Yep.
And finally, we examined the Georgia case study to see how integrating comprehensive, legally compliant, and fully insured teletherapy directly into the school building can bridge that gap and keep kids thriving.
This raises an important question,
Yeah.
one that goes beyond the logistics of school districts and insurance billing.
Okay, I'm listening.
The clinical research is absolutely clear that the success or failure of a mental health day hinges entirely on a very specific, structured conversation.
Right, finding the trigger and building a coping mechanism.
Exactly. But the underlying assumption of this massive societal shift is that parents, teachers, and even the students themselves inherently know how to have that dialogue.
Oh, we're assuming everyone is just naturally equipped to be a behavioral therapist in their living room.
Precisely. If the difference between a child successfully resetting their nervous system and slipping into a dark, chronic pattern of school refusal comes down to the quality of one conversation, how prepared are we as a society to actually guide those dialogues?
That is heavy.
We are building the infrastructure in the schools, sure, but who is teaching us how to talk to each other when the school bell stops ringing?
That is a profound thought for you to chew on today. Because going back to where we started, if you break your arm, you don't just sit on the couch and hope you know how to talk the bone back together.
No, you definitely don't.
You need a mechanism for healing.
Yeah.
The mental health landscape might be invisible to an X-ray machine, but the need for that structural support, both in our schools and in our living rooms, is just as real. Thank you for joining us on this deep dive. Keep exploring the material, keep asking these tough questions, and we'll see you next time as we continue to unpack the ideas shaping our world.